Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman. On this show, you'll receive powerful insights and resources for rural surgeons. I'm a general surgeon in Northwest Indiana, and this show is tailored around the nuts and bolts of rural general surgery practice. But you'll find topics ranging from practical surgical tips to a host of others, including rural lifestyle, finance, training, practice models, and more. We'll have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. Whether you're a surgeon, other specialist, or primary care, or simply someone interested in healthcare for rural America, I'm glad you're here. Now let's get into the show. Welcome back, listener, to the Rural American Surgeon Podcast. Today we're joined with Jeremy Bud Stoller, and he's from Wert, Ohio. Thank you so much for joining us, Bud.
It's good to be here. Thanks.
So I had a great way that we met up. So I was presenting in 2020 at ACS virtually in the middle of the pandemic about training a rural surgeon. And then I left my email at the end for people to reach out. And now over the past 4 years, we've really had an opportunity to kind of grow a friendship and a professional relationship as well, to be able to bounce some ideas off of each other. And I just told Bud he needed to come on and tell us a little bit more about his experience. And so, Bud, why don't you introduce yourself a little bit more in terms of your training and what your practice is like now?
Okay. So I'm in Northwest Ohio, Wert, Ohio, small community, 10,000 people, all rural. It's where I'm from. It's where I was born and raised. I went to college at the Ohio State University, and then I did med school at Toledo, University of Toledo, which is joined with ProMedica now. For those people who might be listening, Toledo's south of Detroit, Michigan, about an hour. Most people don't know where it is. And then I did med school there, and then I stayed there and did surgical residency. And then halfway through residency, I thought, I like general surgery. I just like bread and butter, general surgery. And I'd always kind of kept contact with the hospital from where I'm from, like with their public relations type people. It was always kind of an option, but I wasn't always planning on, going back home. And it just exploring things, figuring out what I wanted to do. I decided I didn't want to do any fellowships, even though there was a lot. That's what pretty much everyone was doing in my program. Not everyone, but most, Mm-hmm. And then I just ended up in Wert, and I love it.
So when did you finish residency?
2017.
17. And what's your practice look like now? Like, what are the biggest cases you do? What's the most common case you do?
I didn't have much experience or exposure to rural surgery in residency. I didn't really know what it was. But then once I got out, I started going to, like, when I went to ACS, I do all the rural surgery things and realized, I'm not alone. I was so surprised by the amount of endoscopy. It's like 50 to 60% endoscopy. That was a huge surprise to me. And then, I do hernias, gallbladders, appendix, all the acute care abdominal stuff.
So are you doing your acute appies on the robot?
Only if the person's really obese or if it looks like a disaster on the inside. But mostly, I would say 90% straight stick.
How about all your gallbladders?
All my gallbladders, all my hernias, even.
So if it's like a biliary dyskinesia, normal gallbladder, what's the skin to skin time on that for you right now after you've been doing it for so long?
I don't know my skin to skin time, but my average consult time, which they follow, is like 22 minutes, I think.
Okay. So. And what do you think it takes you to be docked, inflated at the consult and then after you walk away from the console and go close?
By the time I start, less than 10 minutes before I'm, docked, I would say. Probably.
That's pretty good.
Maybe 15. It just kind of depends on the patient.
Well, great. Let's move to the first section of the show. Why is rural surgery special to you now that you've been out for 7 years? What have you found to be really special things about it? Obviously, going back home.
Yeah. I just like the small hospital. I've always liked the smaller, even in residency when we would go. Of course, the one hospital we went to wasn't really small, but it was private, And I've just always liked how everyone in the hospital, they know you. I mean, if you really want to, you literally can go up to the admin and just knock on the door of the CEO and just say, hey, and talk to him. I always remember in residency, there was this big focus on like doing medicine as a team, like it was some novel concept or, we should implement, team-based care in the hospital. In a small hospital, you like have to do that. It's like a necessity. If you don't know how to work in a team, you can't operate, or you can't do anything. And I like that small, intimate feel of the rural hospital is what really, I think, gets to me.
Yeah, I love it. It's just like the town, basically.
Yeah.
Let's roll into how I do it. So I want to talk about ventral hernia for a while because there's so much nuance to it. People don't want to maybe talk about ventral hernia so much because of that, because there's a lot of times not a right or wrong way to do it. Matter of fact, they've changed the codes about 2 years ago, and the code's now no longer laparoscopic or open. It's just repair of anterior abdominal wall hernia.
Right.
I think that's a good move to reflect the fact that there's a lot of surgeon discretion, but also on the other side of the discretion, not a right or wrong. Like you could have 10 surgeons, 20 opinions about how to fix that hernia.
Well, that's probably because we just don't know, Yeah.
There's some maybe lacking data, but it's, yeah, sure. So tell us, which ventral hernia do you want to start with? Which, patient, mock-up patient or whatever?
I mean, of course, in my practice, it'd be like, the person who's on the verge of needing bariatric surgery. And so there's always that like conundrum, and would have like a, 1 to 4 centimeter defect, whether it's an incisional defect or primary umbilical or epigastric.
So maybe before you say that, are there criteria that you tell the patient, no way? Like BMI criteria, any comorbidities, anything like that?
In Van Wert, like nobody's going to stop smoking. I mean, it's just not going to happen. And maybe I'm a little too cynical in that regard. I'll talk to the patient about it. But honestly, I've operated on so many people that smoke and they do totally fine for ventral, for a straightforward, robotics / ventral hernia with 3 small, tiny incisions. It's like, whatever, but I do talk to them about smoking cessation, but it depends. I definitely won't touch someone above BMI 50. That's for sure. At BMI 40, I have that conversation with them. That's the number I found that a lot of people still use. Although I was like kind of humored this year at ACS, there was a panel session on ventral hernias in the obese patient. And I was kind of like, tickled that like the experts up there finally were admitting that like, it's really hard to get patients to lose weight. So what do we do about this?
Yeah.
Because so many of my patients are just like, I'm not losing weight. Like they're just not going to do it. It's like 40 to 45. I mean, I get really above that. I start to get kind of a little like, I don't know if I want to do this unless if the person's like incredibly symptomatic, I talk to them about the risks, have a conversation, and then sometimes I'll do it,
Well, what I saw in residency was, a strict tertiary quaternary referral center where we ended up using more of BMI cutoff 35.
I've seen that number. Yeah.
And then we would make them quit smoking, improve it with a urine cotinine level, and just have no qualms about just not fixing it. I would say that was, but then it's a big system and there's variation in practice. I'm in critical access setting, and I feel like I had a patient this year that did cry when I told her she needed bariatric surgery, and I wasn't going to take her to the OR.
Yeah.
But normally the people receive the conversation really well about weight.
Yeah.
And I kind of have a a delivery that I think works.
Mm-hmm.
And so because your bariatric referral numbers are 35 with comorbidities or 40, then I just say, look, you meet criteria. You'd actually be an excellent candidate, for bariatric surgery because you're heavy, but you're not like, too
Right.
far gone, and this would change your life. And if I could wave a magic wand, this is what I would fix is your weight rather than your hernia first. And this is why the recurrence rate. So anyway, I have this way that I kind of phrase it. But again, this is why we're talking about it, because there is not a right or wrong. And I definitely have broken my own rule with very symptomatic patients because, I'm worried that they're going to strangulate before we get,
Right. Or they say they can't exercise because it hurts too much, or But yeah, I have the conversation too. There are a number of times where they'll be like, yeah, okay, I've referred them to bariatric surgery, or they'll be. I need to figure out about maybe trying to work the GLP-1 inhibitors into the whole conversation now, but again, with insurance and costs, a lot of my patients I highly doubt would be able to afford them.
The way I get around that is there's 2 medical weight loss clinics. And so I just refer them to that. We're going to make a referral one way or another, medical weight loss, surgical weight loss. And we pick, or a lot of times I just go surgical weight loss. They still talk to them about it. Mm-hmm. And then or refer them back to their primaries, which the primaries a lot of times appreciate that. And if they're diabetic, then they'll get it covered. But if not, then they're going to have to decide something else. But yeah,
it's tough. I mean,
so tell me about you said the 1 to 4 centimeter, say primary umbilical hernia. Okay, that's fine. Before we talk about that, what about the 8 millimeter primary umbilical hernia? So how do you fix that?
If the person's not, if they're, of course, I don't have a BMI cutoff, but if they're smaller, I'll do open umbilical herniorrhaphy, suture herniorrhaphy.
What suture?
PDS, PDS. I'll do.
You just stitch it straight together. Do you do any? Is it simple interrupted sutures or?
I'll do figure of 8s, like small bites usually.
Mm-hmm. So I was at Mayo and I was an intern. Of course, I'm like reading Zollingers, getting up at 4:30, reading Zollingers before I go in and stuff.
Good for you.
And I just remember going in. We had umbilical hernia. I'm like, I'm going to be owning this case, little one, and I'm presenting it. I'm like, I think we should do the Mayo vest over pants repair. And I remember the chief of Department of Surgery. We haven't done a vest over pants repair in 50 years, like the things that you don't forget. But yeah, I just, get rid of the sack and free up the edges, maybe clean it up a little bit and stitch it up just like you're talking about. Yeah. If it's that small, it's usually like 2 interrupted stitch. I mean, sure. Okay. And I got one more question about that though.
Yeah.
You ever done one of those under local in your office?
Not in my office, but I have done them under MAC and local in the OR. And it's not, it's not hard. I had one of the older surgeons, like my staff, an old staff member when I first came. She talked about how the surgeon who was there in the 90s would do that.
Yeah. So I had a primary care ask me that, and I was like, I never heard of that. I don't think so. But then few months after that, I had this patient he was known to me. I'd done like 2 or 3 surgeries on him before already. He was referred for a lipoma of the abdominal wall. It was off midlines, like in the left upper quadrant. And we did an ultrasound. It was this firm rubbery mass, would say probably 5 centimeters in size. The ultrasound said lipoma. And so, but it was pretty good size. And so I actually took him to the operating room and I did it in the OR. But on a day because this is in a critical access setting where we don't have anesthesia all the time. Yeah. So I just did it on one of my local days. Yeah. And so he's wide awake and I'm doing it in the OR lipoma resection and I'm chasing it down to find maybe a feeding vessel or whatever. And all of a sudden I'm like, this isn't ending, and it just funneled down to a tiny, probably 2 centimeter discrete hernia defect. Yeah. And I'm like, hey, this is a hernia. What are we going to do? And he's like, I don't know. What do you normally do? And I'm like, well, normally I fix this with mesh, and I think that's what we should do. But you're under local. Normally I would have you asleep. There's no option. So
Right.
I ended up just using a lot of local, and I did a full out hernia repair using a Ventral ST mesh,
like
and
a 4 centimeter tiny one or something.
I think I might have used the medium one.
Are you serious?
it was either the small or the medium, but 4-point stitch, parachute, dropped it in, closed the defect over the top, and he did fine. So then after that case, I'm like, this was actually bigger than just a fingertip belly button. I definitely could do a fingertip belly button in the right patient in the clinic under local, but I have never actually done that myself. I just thought I'd ask.
Yeah, I've seen debate actually. I really follow the hernia closely because it interests me. For a while, I really am appreciative to the IHC, the International Hernia Collaboration, the Facebook group, seeing the discussions there, but there's it's like, well,
there's a lot of robot bias on that. But yes.
Is it less than 2 centimeters or can you go up to 2 centimeters for the suture herniorrhaphy, or is it really just 1 centimeter? I would say most of my patients are bigger, and as they get bigger, even if it's smaller, if it's 8 millimeters, really small, okay, sure. But I don't like doing a suture herniorrhaphy in someone with a BMI of like 35,
right?
And so I'm just like, I'm going to do a mesh repair on you. Like, I don't, it's just, again, no data whatsoever, but it just, to me.
But you're going to put in 3 8-millimeter ports that you're not going to close.
Yeah.
Right.
Yes.
And you're going to fix the 8-millimeter.
I'm gonna play the odds that they're not going to get a port site hernia. Nobody knows. Nobody knows what the rate of port site hernias are, especially with the robot. With the 8, it happens, but I don't. As far as I know, nothing has been. I'm not sure. Yeah, it's low. It sounds like, but
just devil's advocate. I'm not saying you're doing the wrong thing. I mean,
well, trust me, I'm aware. I'm aware of.
Yeah. So, okay, let's carry on to the routine guy that comes in. He's got a BMI of 33, so we all agree, and he quit smoking or whatever. So you got him optimized, and everybody agrees you should fix it. We'll make it easy for people, so they don't Monday morning quarterback us when the recurrence happens. But you've got it's 3 centimeters in size, especially with the new coding guidelines. It's 3.0. And what are you going to do?
So, are we going straight to the surgery now at this point?
I think so. So you're going to put him in the OR, general anesthesia, arms tucked?
Yes, arms are tucked. Sometimes the right arm stays out. But again, I have jumped all in with the robot. So this is all robot. I should mention we have all CRNAs at the hospital. Thankfully, coverage 24/7, and they're all fantastic. Like, I would let them all do my anesthesia.
Sure.
So put him to sleep, tuck the left arm, usually tuck both arms, prep and drape. I do varus needle entry at Palmer's Point exclusively, unless if there's something that's. But yeah, in general, if this is straightforward hernia, varus needle entry, Palmer's Point, 1 or 2 finger breaths below, midclavicular vein below the subcostal margin on the left side, saline test, get it in. I hate the varus needle, but it is what it is.
Yeah. I don't know if I've talked about this on the podcast. Perhaps there's a listener who's a resident or whatever, medical student. So a varus needle is a retractable needle that you can use for entry. And when he's talking about saline test, what you're doing is you can look up Palmer's Point. A picture's worth 1,000 words. But yeah, midclavicular line 2 centimeters below, or 2 finger breaths below the rib cage in the left upper quadrant. Now, are you making a small nick with a 11 blade?
I am, yeah, small nick.
then you're just feeling through the layers with this Ferris needle, and then it pops through your muscle layer. So describe what you're feeling there.
Technically, you're supposed to feel 3 pops. But as I've done it more and more and more, sometimes it's 1 big pop, sometimes it's 2 pops. And as you do it more, I felt like you just kind of get a sense of when you're through. But when you're first starting out, it's so confusing.
So the reason he's feeling 3 pops is because you're medial to the semilunar line. And so you're feeling anterior and posterior fascia and peritoneum. Those are the 3 pops.
Yes.
And then the needle will self-retract then and become like sort of blunt.
Yeah.
And then you're just holding it, your wrist is bracing, so you're not plunging, and you're just going with your fingers and your hand basically to push it through. And then use a little bit of saline on top of the open needle. And if you see it drop in to the abdomen, then you feel real comfortable hooking the gas up, and you do your insufflation. Now, when we're insufflating, again, this is for the trainee, but typical abdominal insufflation is 15 millimeters of mercury of pressure. Am I saying that? It's not centimeters of water. Millimeters of mercury pressure.
It's millimeters mercury. Yeah.
And high flow would be like 40 liters a minute.
Yes.
Would be like high flow. Low flow would be 3 liters a minute. So these are settings on your insufflation machine. But if you hook up high flow to a Ferris needle, you will never get more than 3 liters a minute anyway, because of Pascal's law, I believe, which is going to be your resistance against your circuit. So just something to be aware of. Now, while we're on this very boring topic of physics, let me ask you, if you're doing another type of entry besides Ferris needle, do you go straight? Do you ever like slowly insufflate for a little bit for any reason to see how it goes with anesthesia? Or like for me, where I'm going with this is I put a Hassan almost always, and cut down technique Hassan, which is a 10-12 port, that I put in bluntly. Yeah. And then I just go straight to 40 every single time. And it's like a discussion with the staff. Like for some reason, I can't get them to always do this. Is there any drawback to that? Like they're going to get hemodynamically unstable or something?
I do the same thing. I go straight high flow, but, and I had the number of times where, the patient Brady, so you turn off the gas. And I had a patient last year where we insufflated, and I was a little tricky because she had a huge left lobe of the liver. My Ferris needle went in the left lobe of the liver, of course. But I think ultimately she was young, healthy. What ultimately happened was she just had this vigorous vasovagal response and just coded. I mean, it was terrifying. And ever since that, if anesthesia says bradycardia, I pop on the cannula.
I just release the insufflation right away.
Yeah, I pop it and immediately just desufflate the abdomen. I had an attending who would used to do that, and I always thought it was kind of weird. Now I understand.
Yeah. There's the power of experience. Okay.
Yeah.
All right, Dr. Lehman, get back on track here. Your listener's fading fast.
Okay. So pneumoperitoneum, I put in 3 VisiPort, 3 8 millimeter robotic ports on a left lateral abdomen, direct visualization, dock the robot, go onto the console,
take your shoes off,
take my shoes off.
Yeah. I'm
telling you, the robot, it's amazing. I will never go back to straight sticks. I'm telling you, it's amazing. So,
all right. That's fine. I'd probably be there eventually, but I'm in 4 hospitals. And so my situation, I don't have a robot. I trained, I was certified when I left residency, but I haven't been using it for 5 years. So, and it's going all right, but this is the beautiful part about it. So carry on.
Yeah. So then I reduce whatever's incarcerated, reduce it. And then, I strip the peritoneum. There's always I don't think there's any data to this, and I noticed people started doing this or advocating for it maybe within the last 10 years or so. And I think it makes sense. It's like, what, don't put a mesh up against fat. You want that mesh to touch the fascia, So there's always this middle strip of peritoneum that you see, and I take it down. And if, depending on the size of the defect, and if I think I can, that's when I'll do like what's called the RTAP, the pre-peritoneal repair. I don't lose a lot of sleep if I can't do it, because forming that pocket around the umbilicus and epigastrium, making it big enough to fit like a 10, 11, 12 centimeter mesh in, can be really hard. And I used to lose a lot of sleep over it, and now I'm just like, whatever, So I take down that midline strip of peritoneum, but I just make a pocket, and so it's just hanging there. And then I close the defect. After I take that down, I close the defect with a barb suture, like an OV lock generally. If it's bigger, I'll use an O-Stratafix. Once it starts to get big, even up to 7 centimeters, if I'm doing like an IPUM.
And usually close that vertically or transversely, or just however it looks?
I don't close it cephalad to caudad, transverse. Okay. I would call that transversely is what I would call that.
Right.
Sometimes I do. If it seems like if it's like a weirdly shaped hernia, I will close it transversely. But generally, I'm closing it from the patient's right to left. Like, you're closing the midline. Does that make sense?
Yeah. Yes.
Yeah. So that's like the IPOM plus, what they talked about within the last, 5-10 years, probably closing the defect actually. So I do that, and then I'll put in the mesh. Gosh, what do you, if it's like 1 to 3 centimeters, I'll probably do like a 10 to 12 centimeter mesh. Once it starts to get beyond that, I'll do more like 12 to 15. Or bigger, as it gets bigger.
So it's 3.0 for this guy. So you do probably 10 centimeter.
Yeah, 10 to 12 centimeter mesh.
Okay. And you cut it like an oval, or how do you?
Well, if I can get the pocket, then I'm doing an RTAP, and I use a medium weight polypropylene mesh, uncoated, and I put a little stitch right in the center to mark the midline, or to mark the very center of it. And I save my barb suture. I don't cut it at that point. And I work and I go back myself right to about the center of the defect. Mm-hmm. And then I'll put that barb suture right through the center of the mesh to kind of make sure I'm centered. Mm-hmm. And then I use a 3/0 barb suture on the right lateral aspect, and I run it laterally. Mm-hmm. So this will be under the rectus sheath. Mm-hmm. Parallel to the midline.
Meshes down, and you're stitching.
Meshes up.
The back meshes up. Okay, because I'm imagining it down, and you're stitching the back layer and then folding it up. But no, meshes
the mesh
up.
Is up and with my center stitch.
Yep. Okay, gotcha. That's tight.
And then I do the barb suture laterally along the right lateral rectus muscle. Mm-hmm. It'll cover like the central portion, because I don't know. I just don't like just ripping that out and removing it. So it's a little tedious. It adds time, but I don't know, makes me feel better, I guess. And then the mesh is secured elsewhere, just as opposed to not just the periphery. Because I don't like it with the intraperitoneal underlay mesh when you secure the perimeter and it doesn't feel like it's touching anywhere else. So I like having
maybe a setup for a seroma. Now you did anchor it in the center, I guess.
I did, yeah. But sometimes I don't. I'll remove that stitch after I get it secured peripherally.
So you start about 5 to 6 centimeters lateral to the midline for making your peritoneal defect in with your 10 to 12 centimeter mesh, and then take it 5 to 6 centimeters to the other side of midline, and that all falls
down. Yeah.
How big does a defect have to be, or what other things would push you to do something beyond this approach you just described?
Yeah, so somewhere around, some people go up to 8 centimeters in terms of the IPOM. And I've done like 7 centimeter defects. I think I've done 8 centimeter defects, and it totally comes together. Now I'm using a much bigger mesh.
So once it's 10, now what are you doing?
Then I'll look at doing a Rivstopa, or if I can, maybe an ETEP. I've done a handful of TARs, but I don't know. I'm thinking I'm not going to bother with that. I just don't do enough, and I'm just like, they need to go somewhere else. It's not in my hands. You know what I mean? But yeah, then I'll consider a Rivstopa, and I'll do that robotically too.
So how are you accessing when you do that?
If the only Rivstopas I've done robotically have all been what's called ETEP, and what that is that you use an ultrasound to mark out after the patient's asleep, prepped and draped, to mark out the anatomy of the rectus muscles. And you go in, it's usually left upper quadrant. The first one is on the very lateral edge of the rectus muscle, and it's a visiport. And you just watch, and you get into the posterior rectus space, and then you insufflate. Use the camera then to kind of open up that retrorectus space. And then once that space is opened up, place your 2 other ports into that retrorectus space. Now you have to have like a wider rectus sheath. I think it's like you need more than an 8 centimeter wide sheath. If the sheath's really narrow, I mean, it's like there's no space, you know? So you need a nice wide rectus muscle to do this. And they have that formula where it's like the rectus muscles, the width of the rectus muscle needs to be twice the length of the defect or something like that, if I remember right. I always have to look it up because I always forget. And so then you release the medial edge of the rectus muscle once you've cleared out that left retrorectus space minimally invasively. You release the medial edge, and then you're getting into the preperitoneal space. And then from there, you reduce the hernia. The important part of this is that on the CT scan, you really don't want to see the bowel plastered up against the posterior rectus space because you worry about injuring bowel and stuff like that. And you really need to keep the hernia sac. That has to be the posterior wall or like the posterior layer. Because with retrorectus, I remember when I was in residency, I was so confused, and even learning it when people were first talking about this approach. Like you don't when you're doing this approach robotically, at least for me, and as I talk to my friends who do it, you're not approximating the posterior rectus sheaths together. Like the layer, you're completely releasing the posterior rectus sheaths, and then it's the peritoneum and the hernia sac that form the bridging posterior layer to then the other posterior rectus sheath that you release. Does that make sense?
Mm-hmm. Yeah, it does.
It took me, and that's, and then as you close any holes in the peritoneal layer there, any holes in the hernia sac, and then that's just your posterior layer. That's the release, and then I'm releasing the right posterior rectus sheath, getting into that space, and then putting in a nice size mesh based upon uncoated mesh. And then closing the defect with barbed suture, and then putting in the mesh then after that point. And I don't leave drains if it's just a straightforward, minimally invasive.
And you're bringing in a uncoated polypropylene big
correct.
mesh,
mm-hmm.
and you're stitching it in the center.
No, it's just filling up the entire pocket that you make.
Mm-hmm. And how do you put any stitches? No,
not if it's a minimally invasive, like totally extraperitoneal ETEP.
Yeah. Have you had seroma problems with that?
Once or twice, but I never drained it. Patients did fine. And I think it was all incidental.
Mm-hmm.
Yeah.
Wow. Yeah, that's a great case. And then you're talking about, open reef stopa with a tar or robotic with a tar, being something that you would currently send out for the most part.
Yeah, I've done it. I was like, oh, I'm going to do this, but I just don't see enough. And my patients did okay, thankfully, but like
Mm-hmm.
it's long, it's complex.
Mm-hmm.
I don't want to mess the patient up. I mean, they talk about those
Yeah.
disaster complications,
Yeah, do no harm. Got it.
Yeah.
Well, this is great. I think we should move on just because of the sake of time, but we could talk. I'm sure we could talk all day. This is a great intro primer. And then some of that stuff, if you are a resident, you're going to have to be doing some more videos.
Yeah.
But luckily, robotic area, you get excellent videos so you can watch all this. All right. So that was the how I do it. We can move on to the financial corner. Do you have a particular money tip to share with our listener?
Yes, I do. So I'm your typical doctor. I know nothing about finances, but my dad is an accountant, ran a practice forever. My brother took it, he kind of bought my dad out from that practice. It's a private firm. My other brother's a financial advisor. So I surround myself with people who know what they're talking about. And I put an enormous amount of trust in them. And my wife manages the finances of our house. But my dad, through years, decades and decades of being a CPA, he had these rules. And his one rule was don't let more go out than what comes in. And that's the driving rule. I mean, yeah. And, I graduated residency. We just paid off our debt. Just that was number one priority, getting the debt paid, getting the mortgage paid on the house. Being, I guess, frugal in that regard. So I'm a big believer in that, and just being careful with how you spend your money. That's about it, though. Sorry, I'm not.
It's good. The expectations versus reality. I heard recently that happiness is the difference between expectations and reality. Something like that.
Yeah.
And there's another quote that what you said made me think of financial wise. It's I believe, Charles Dickens character. Annual income, 20 pounds. Annual expenditure, 19 pounds. 19 shillings and 6 pence, result happiness. Annual income 20 pounds, annual expenditure 20 pounds ought and 6, result misery.
Yes.
Just a little margin, which I mean, I'm a big fan of a bigger margin than that, but
yeah.
That's great. More coming in than going out. Did you have a classic rural surgery story to share with the listener?
I like this one. So I live on like the main drag that goes through Van Wert. It's a two-way, it's Highway 127, and it connects two big interstates in Ohio, or like 4-lane highways, and the truck traffic is ridiculous. I mean, hundreds and hundreds of truck traffic, throughout the day. And I had a patient that I saw, and he's a truck driver. And I was following him for a wound. It's a long story. Won't get into it. And he came into my office one day and he said, you know what? I was having a really tough day, just down in the dumps. And I drove by your house and your kids were out in the front and they were doing this. You know what this is?
All right. Yeah. Honk for me.
Honk for me, that, where you're pumping your arm. Because I was teaching my kids how to do that. And he's like, and I saw your kids pumping their arms and I honked my horn and it made my day.
Man.
And I was just like, wow. And he was like, not many kids do that these days. And he's like, doing that? That was great. That made my day. The last story is my second operation. When I first started, brand new tending, strangulated hernia, textbook, I was like, oh yeah, I can do this. I'm like fresh out of residency, walking in the room. It's the mother-in-law of my dad's longtime fellow CPA.
Mm-hmm.
So there's that connection. I
Mm-hmm.
grew up knowing, I didn't know the patient,
Yeah.
but it was the patient's mother-in-law.
Yeah.
But then it was the grandmother-in-law of one of my best friend's fiancés. So one of my best friends, he's married to he's getting engaged to this girl. It's her grandma, And so then I do the operation. She does well. Of course, then it's like, as I'm doing the operation, my mom comes over to the house and she's like, I hear that Bud's operating on so-and-so, to my wife. And I was like, I don't know, And then the next day, my brother, who works with, the daughter of the patient, he texts me, hey, I heard you operated on so-and-so, and of course I'm like, I don't know what to do, because it's like you can't talk about patients, and
right.
That was an experience, a learning experience for me. Like, how do I maintain patient privacy, but like everybody knows I operate on the patient anyway, So
yeah, but people really like it when you use discretion.
Yeah,
and then people love it when they ask my wife about surgery that I've done on somebody. Everybody knows, and she has no idea. Sometimes, let it go, and they love that, because then they know, hey, I know everybody in my community is going to know I had XYZ surgery, but it's not that my surgeon, who I trusted to like enter my body, and put me to sleep and, do surgery on me while I'm asleep and I'm very vulnerable in that scenario. He's not the one that's talking about it. So those are some classic rural surgery stories. I love it. Yeah. Lastly, I know you're involved in ACS, but did you have a resource for the busy rural surgeon before the busy rural surgeon gets to his day? Yeah,
I the social media forums, they have their place, they have their limitations, but they're like a life source for me, International Hernia Collaboration, International Robotic, and then there's another app called Surge On, which is that's its own app and its own social media platform. That, and then General Surgery News, amazing. Love General Surgery News.
I've seen your articles. Yes, very good, Professor Stoller.
And then that's it. And then the ACS forums did a great job this year for the rural surgeon. I mean, fantastic panel sessions and for the rural surgeon. And we've had a running text thread since we graduated, discuss cases, get their thoughts, and then other of my residency friends that are still in Toledo. It's nice. You just text them, send them the CT.
Yeah,
stay
it's
connected.
Fun to keep up, and then it's also part of your adjunct for your practice.
And then you.
So. Yeah, I don't know how it worked out, but we talk about cases all the time, especially big skin cancers. And if you come back, that's what I want to talk about next.
Yeah. Awesome.
So thank you so much for joining us on the Rural American Surgeon. This has been our show with Dr. Stoller. We will catch you next time. Thanks for being our listener.
Thank you.